It's my pleasure to introduce the United States Chief Technology Officer, Todd Park. Todd has been an amazing person from day one. I think you all know his history. He was an entrepreneur. He was a co-founder of Athena Health. He's been the privacy officer for HHS. He's now the U.S. Chief Technology Officer. But I have to tell you the most striking thing about him, if you don't know him yet, and what he's well known for in Washington is he is trusted by everyone. This is a tricky town, you know. This is a tricky town, and there's a lot of agendas. And one of the things that he does is he is a person of real integrity and tremendously known for his enthusiasm also, but also for how trustworthy he is. And so anyway, we're very honored that you've come to talk to us today. And we don't know the title, but I'm sure it'll be wonderful. So please welcome Todd Park.
Oh, it's my pleasure.
Yes, at least we got you to the right place today.
So thank you so much, Deb, and to all of you for having me over. It's a great honor and delight to be here. And what I'd like to do today, actually, is just offer you some brief thoughts on the whole notion, the whole imperative of giving patients the ability to get their own data, giving patients the ability to get their own health record data. Last week, if you were monitoring the internet, there was a following interesting headline that materialized, which was the following: Cupid.me is hacking HIPAA to encourage safer sex and help patients get medical records. So it turns out that Cupid.me is helping patients get copies of their own STD results and share these results as they wish with potential partners. That's a service that is useful to many folks. Not really to me, but useful, I'm sure, to many. The only thing is, they're not hacking HIPAA. They're actually enabling its most essential function, right? The only right to information in HIPAA, other than for oversight, is a patient's right to their own information. HIPAA outlines other permitted uses, but those are may, not must. In 2013, HHS's Office of Civil Rights clarified in regulation that the right of patients to get their own information extends to patients' access to the digital information in their electronic health records. This is pretty powerful stuff, and OCR thinks so too. In fact, in 2011, OCR fined Signet Health $4.3 million for denying patients access to their medical records. To make sure that every patient knows about this right, last year, OCR published a letter to patients, a right to access memo, which I'm sure you all have seen, which is a fantastic document. And I feel a little silly sharing this info with you because you're a group of privacy experts who know HIPAA backwards and forwards, but I do so to underscore that from the very top of government, we're incredibly serious about making sure that patients get a copy of their own medical records, whether on paper or electronic, so they can take control of their own healthcare. Having access to electronic health record info is a simple but powerful tool for patients. They can spot errors in their billing records, they can share information when they are referred, they can better manage chronic conditions and medication regimes. And we've taken this concept, and with many, many others, including folks in this room, we've turned it into a movement to give patients easy ways to securely access their own electronic health record data, a movement called Blue Button. The Department of Veterans Affairs, the VA, first used Blue Button on its patient portal, My Healthy Vet, in 2010. By clicking on the simple, beautiful blue button after you logged in and authenticated yourself, individuals could securely download their own records in digital form. It actually, interestingly, began with very simple data, actually the data that you had self-entered into the portal. But now you can download essentially your complete electronic health record from the VA's EHR system in your Blue Button file, which is actually quite amazing. And with a large share of veterans, this has been an invaluable feature. In fact, since its release, literally millions of veterans have logged onto the tool to download securely their own Blue Button information. And this is actually now spread to many other organizations, such that today, over 88 million Americans have access through a Blue Button type capability to a digital copy of their own health information or health claims. So this includes all seniors covered by Medicare can get their Medicare claims through a Blue Button file, military service members, enrollees in private health plans like United Healthcare and Aetna, and this number of Americans with access to their own Blue Button data is expected to grow to 115 million by the end of this year. And over 400 companies and organizations have actually now committed to give their patients, their customers, access to their own digital information or develop tools for patients powered by this data. We're now actually seeing this Blue Button movement intersect with another movement, electronic health record adoption. So last week, as you may have heard, it just announced that more than half of doctors and nearly 80% of American hospitals are now using electronic health records. This is an increase of multiples, literally multiples, on both sides, doctor and hospital, since 2008. To get the meaningful use payments, Medicare and Medicaid bonuses for meaningful use of EHRs, for going digital, providers need to track and report their quality. They need to use clinical decision support to avoid errors and improve care. And most importantly, from my perspective, starting in 2014, starting next year, they all of them need to give patients the ability to view, download, and transmit their own health information. Providers and hospitals don't just need to make this service available in some kind of Potemkin service. They actually need to ensure that at least 5% of patients are actually using it, which really compels them to put pedal to metal and rubber to road and make this a real thing that patients can use. So every single EHR vendor in America is hard at work right now, if they haven't already done so, building these capabilities into their systems. Patients will be able to get coded, standardized, rich data. That's their own data. So now you might ask, like, why would patients want coded, standardized data? Well, patients don't want to just store and file their information. They want to use it. And when the information is digital, when it's shared with them electronically, when their medications are coded in RxNorm and their diagnoses are coded in SNOMED CT, what that means is that innovators and developers can build tools for patients that can take that data and make it really useful for them, help patients take care of themselves, live healthier lives, manage complex conditions, and much more. Actually, last night, I met with a group of entrepreneurs and innovators and developers, patients and doctors at the Health Data Palooza that are really focused on these issues, really focused on expanding access to Blue Button files and building tools for patients can use to take that data and help them actually accomplish all kinds of useful things. And there's something more as well. When patients can get their own information electronically, they become what more and more people are calling a health information exchange of one, what we call patient-mediated, patient-intermediated data exchange. A really, really simple and powerful concept. And when the patient is the one doing the aggregating and the assembling and the sharing, a lot of the complexity in traditional health information exchange is actually reduced. We just have to make it really easy for patients to get their own information and really easy for the services patients use to receive that information and make sure this information is safe and secure throughout the entire process. So how can we really turbocharge all of these efforts? Last year, we launched a new initiative from my office at the White House called the Presidential Innovation Fellows Program, which basically brings in top innovators from outside government, tech innovators, to work with top innovators inside government on game-changing projects to develop solutions that can save lives, help save taxpayers money, and fuel job creation. 3 of the fellows in the inaugural class and 3 of the fellows coming into the new class that's about to arrive are focused relentlessly on how to take the ingredients I just discussed and really drive forward patient access to their own information and patient use of their own information. These fellows have been working tirelessly with a whole bunch of folks inside and outside government to develop and drive adoption of a set of protocols called Blue Button Plus. Blue Button Plus that will make Blue Button data machine readable and define a secure way to transmit this data easily to consumer applications of consumers' choice. 68 health tech companies and organizations, including electronic health record companies, health plans, and patient privacy organizations, have collaborated on the development of the Blue Button Plus protocols. In March 2013, at the HIMSS 2013 conference, 6 companies and their healthcare provider partners demonstrated Blue Button Plus implementation progress, including Intuit Health, Allscripts, Beth Israel Deaconess, Greenway Health Vault, and No More Clipboard. For an EHR, Blue Button Plus means giving patients a way to get and send their structured information using the direct protocol for transmit and CDA for structure, And the good news is all built into requirements under the Meaningful Use program. Building in automatic triggers so patients can direct their information to be sent to a secure location of their choice on an ongoing basis without having to continually sort of hit download, download, download. And then uploading the patient certificate bundle to enable direct to patients. So here's my invitation and ask of all of you. The quicker we can get these functions built into EHRs and patient portals, the more rapidly we can help healthcare providers with the workflow of sharing information with their patients. The faster we can jumpstart an ecosystem of apps and tools that patients can use. The sooner we can get patients asking for and using their own health information. So you can check out bluebuttonplus.org, bluebuttonplus.org, and reach out to Ryan Panchatsram. It's kind of a, let's see, so his email address, you can actually email me, tpark, T-P-A-R-K, at ostp.eop.gov, tpark, T-P-A-R-K, at ostp.eop.gov, and just put Blue Button Plus in your email headline, and I will forward that all to Ryan, who's a phenomenal, phenomenal guy. Folks are ready to go, protocols are ready to go, and the protocols are not hard to implement. The sooner we can do this, the sooner we can actually get to a world where patients really can control their own healthcare. So whether you're a vendor or an advocate or a policymaker, patients need your help. Patients need your help this year. Now, some providers may be reluctant and nervous to give patients access to their own information. They're used to thinking about the health record as the provider's record, not the patient's record. But this reluctance often disappears in practice. For example, researchers undertook a year-long trial of open notes in which 105 doctors shared their notes with more than 19,000 patients in Boston, rural Pennsylvania, and Seattle. The project found that when patients have access to their doctor's notes, they feel more in control of their own health care, better understand their medical issues, and report that they're more likely to take their medications as prescribed. Virtually all participants supported the idea of seeing their medical notes, and very interestingly, no doctors, not a single doctor, elected to stop sharing visit notes with their patients once the study ended. We're in the middle of a huge cultural shift, a cultural shift of seismic proportion and incredible importance, a movement to give patients access to their own information, a movement which actually promises to generate enormous benefit for patients. Leonard Kish says, patient engagement may be the blockbuster drug of the 21st century. It's a movement that's going to take learning and change for everyone, but it's a fantastic path to be on and a fantastic destination, and we're definitely getting there at an accelerated clip. So as my colleague Ryan Panchatsram said in his closing talk this year at TEDMed, we have the rights, we have the tools, we have the talent. It's now up to all of us to follow through, to execute. And we can do this. We're already making huge progress. There's much more work to do, but we're actually making progress at an accelerating clip. So thank you to all of you who have already been part of this, making this happen. Let's keep at it. Let's get this thing done. And this is work that will save lives. It will improve lives beyond measure. It'll make our healthcare system vastly better. It's the right thing to do, and we could not be more excited to be part of making it happen. So thank you so much for having me over. We're very excited to be here, and may the force be with you.
That was quick. We'd love for people to be able to ask a couple of questions. So I think we're all in agreement patients should get their information, and that's the first step to controlling their information. And people, does anyone want to ask a quick question or two? Yeah.
Okay, so my question is, has sequestration at all impacted rollout and implementation and sort of development of Blue Button Plus?
It actually has not. So one of the really phenomenal things about the Blue Button effort is that it is very much a public-private collaboration. And so the Blue Button protocols have actually not been developed by some secret government program somewhere, right? But by this open, collaborative dialogue and work effort by a whole bunch of people, including people in this room. And that's not only actually the smartest way to get things done, it's actually radically more efficient than hiring some secret government contractor to actually put something together. So that actually helps make it much more sustainable And again, is just vastly more effective than other approaches. So we're very, very excited about that. But that's an effort that to succeed depends upon continued engagement by folks. It's actually powered by the people that choose to participate. And so we just ask that people keep plugging in, keep joining your efforts with others, and that way we know that Blue Button Plus will be super successful. And actually, just to add a few more kind of bars to that particular sheet of music, the direct protocol that is a key ingredient in Blue Button Plus was actually developed similarly through a kind of crowdsourced, collaborative, open dialogue. And it's been called at HHS like the single most effective healthcare standard development exercise in history. It cost about 1/1000th what it normally costs. And in terms of like efficacy and adoption, it's like an order of magnitude or two beyond what traditionally happens. And so, but again, it's powered by you. So if you plug in, we'll be good.
Melissa?
Okay, it sounds great, but what if I get my record and there are things in there that I don't want other people to see? I don't want the dermatologist to know all about my libido problems, or anybody to know about those abortions, or, I know drug use does have its own protection, but there are a lot of medical issues that a lot of people don't want to have shared, and that's kind of the whole, what's going on here. So how does Blue Button handle those issues?
Well, so these are really good questions for folks to develop. And I actually also have to, just as a general caveat, say that I am still a Padawan apprentice when it comes to all the intricacies, I think, of privacy. And so I've learned a lot from Deb and others, and Joy Pritz, who are kind of Obi-Wan Kenobi-ing me, kind of up the curve. But one of the things I really love about patient intermediate data exchange is it just simplifies a whole bunch of stuff, right? So basically, I'm sorry. I can go either way. But it just makes things a lot simpler, right? So for example, and this may raise other issues, right? Again, but just kind of speaking, just from a relatively kind of simple perspective, if I'm basically the person who gets my own data, right? And then I actually go and see other providers or other folks I want to share it with, I choose to share with them what I choose to share with them, right? Because it's actually my data coming to me, and then I choose where it goes, right? And so I think that's actually very attractive. Now
For segmentation.
Right, exactly, right? Because the patient actually literally controls what goes where and to whom. Now, the question I would actually pose for you, which I'm sure you've talked about and written about research endlessly, right, is what, and I actually would really love to know the answer to this, and there may be already a well-established answer to this, but, what if, I make a redaction decision that turns out to actually be not wise, right? Like I may think that that was something that I wanted to withhold, but turns out that the doctor who saw the information, without that piece of information, makes a diagnosis and executes a regimen of therapy that actually ends up being really bad for me, right? So that I just don't know enough about clinical dynamics to really understand this in a lot of detail. But what I would say is, just to answer your original question, it's very attractive to me, just from the standpoint of information management, that information goes to a patient via Blue Button, and then I, as a patient, decide where it goes. I decide what goes to whom and where and when. And there are other questions that get triggered by that, right? But as kind of a baseline underlying assumption, that seems really, really good to me.
Todd, in regard to redaction,
Yeah.
I think we don't have enough trust in patients. I think if people want to redact something,
Yeah.
then they ought to be able to be told what the consequences might be,
Yeah.
and in what situations it might be useful. But people are pretty smart.
They are pretty smart.
And so I
are
don't
pretty
think
smart.
we have to worry so much about the dangers if people actually have
Right.
enough information to make reasonable decisions.
I think you're right. I mean, it's
So-
interesting because I can't remember who did this study, but
And take the liability for it and understand what it means if they,
right,
the consequences, you know.
right. And so I'd love to learn more about that as well. But,
Sure.
oh, sorry.
Okay.
So like one interesting study I saw recently was, like people were saying, oh, well, people don't really want their own information, but it turns out it's actually not true. People who are healthy, except the quantified self folks, don't tend to care as much. The people who are not well care a ton, right? Care an absolute ton. And you would think, to your point, they're pretty incented, right, to make sure that
The right
they're
people
passing
get
along the information, right? And so, and I'll just tell you just from personal experience, because a lot of this, it's all informed, in a certain sense by folks' personal experiences. But my baby daughter recently had a health issue, and when she was just after she was born. And so my wife and I basically went through the exercise, which I'm sure a lot of you have done, of trying to get my baby's health information from all the different places. And boy, was that really, really hard, like unbelievably difficult. And I am not afraid to say that actually, without getting into details, that in a couple of situations, imperfections or incompleteness of the information
And errors.
put my baby at risk, right?
I believe you.
And so I would be, maximally incented, I would say, right, to make sure that the information being passed along is maximally actionable. But so that's a really good point. It's a really good point.
Thank you. How much time do you have, Todd?
I kind of have to skedaddle,
You
but
do?
you know what? I'll stick around for another maybe 10 minutes. Is that okay?
Okay. So quickly.
I have not had, I need to look at the Blue Button Plus, but I'm glad that you're finally structuring the data underneath it. Hopefully it's in a schema of some type.
It is.
And hopefully you've included in that schema something like a provenance, which basically says where the data is coming from. It'd be interesting if you put fields in there for consent that would be passed along. You'd inherit the consent privileges, because one of the things that's really powerful if you ever get the data in structured format is we can actually do quality analysis for the first time. We can do longitudinal analysis, which we haven't had the ability to do. And to do that means you're going to be merging the data in a big data way with other data sets. To do that, I think the patients need a sense of understanding what classes of consent that they're consenting to. And it doesn't seem like that's been developed. And it seems like if you want to actually deal with the issues in the last panel, you need some technical structure embedded in the data that enforces some of that.
So I think, is Claudia here?
She's hiding.
Hi.
She's
So
here.
hello. So I think, does the consolidated CDA actually have provenance right now?
There is someone with provenance in the header.
Oh, can we let Claudia go to one of the microphones so people that are watching and also in the audience can hear? Thanks, Claudia.
Yeah, there is some provenance information in the CDA header, and one of the challenges and opportunities from a tech perspective is how you perpetuate the provenance as you integrate the information to the EHR. So that's the kind of thing we need all of your great thinking on as we move into stage 3 and stage 4. So as you pull that information and you want to continue to know where it came from.
Is there a way for people to input into the classes of consent that you'd want? Because we obviously haven't thought about what consent means and who should look at what, particularly as you're merging data.
I think we're at very early stages of looking at electronic management of consent, but it's something that Joy Pritz and her team, along with I think many of you, are looking at through various projects, including the data segmentation work that's being done with the standards group at ONC. Thanks.
And one of the things when I first met Deb that I just found incredibly attractive as a concept was this whole idea of making consent understandable. The incomprehensible consent isn't incredibly effective, right? And so this kind of massively granulated, super complicated, kind of consent framework would just be a lot less effective than say, okay, look, here are some, a set of basic understandable choices. Yeah. And so, and again, just helping me come up the curve on this stuff. Have folks developed kind of straw cases, what they might look like in terms of what a consent framework that's really truly usable and understandable by patients would look like? And has that been tested?
No, we'd love your help to test it.
Aha,
What
that's right.
a great
That's what you and Latonya are talking about.
question.
Yes, okay,
yes,
great.
we would love to.
Because I think that would be hugely, hugely helpful. So I guess we'll talk more about that.
Okay, we'll talk more about that. Sorry.
Thanks, Todd. You mentioned it was interesting, the conversation around the physician notes being available and how patients were happier to get them and so forth. Was there any measurable efficacy in terms of patient engagement and ultimately outcomes or wellness or health? Or how did that affect the overall population health?
So actually, and we can actually get the more detailed data, but it actually improved propensity to adhere to medications and other factors. And this is actually similar to more and more studies of patient engagement that are being done, where it turns out that the more patients know, the better the outcomes become for a variety of different reasons. And so there's a tool, for example, called Archimedes Indigo that presents to both the doctor and the patient at the point of care, right? Kind of probabilities that something is going to be helpful to you over a set of different options, right? And that actually increased medication adherence for cardiac patients at Kaiser Hawaii dramatically, and increased the overall risk of heart failure, decreased the risk of overall failure by about 13%. So I think what we're learning is that information can heal, but only really, truthfully, most powerfully if it's in the hands of the patient. So that's one of the reasons why we're so excited about this. We don't think it's academic. We don't think it's nice to have. We think it's actually a fundamental component of the healthcare system of the future, the one we should have.
So you see a potential correlation between what we refer to as big data, which is all this machine data and all these other things, and patient engagement.
Yeah, so I mean, big data is one of those terms that means a lot of things to a lot of people. You know, I mean, I would say whether it's big, small, medium-sized, polka-dotted, short, tall, you know, I mean, data that's relevant to a patient that you know, could be used by that patient to help the patient should be made accessible to the patient. You know, put that information, put that knowledge in the patient's hands, and I think really good things will happen. And there's more and more empirical data to demonstrate that.
Thank you.
Thank you, Dr. Park, for your comments. I'm Asim Padella.
I'm Mr. Park, I'm not a doctor.
Mr. Park.
Just Mr.
So actually, I want to push back on that for a second with two examples.
Sure.
So I think that what you're suggesting, that more information leads to better outcomes, is yet to be proven. It's a hypothesis.
I think so. You're totally correct. I should amend what I said. I would say that there are more and more examples of how the right information delivered in the right way, you know, in the hands of patients is very helpful. That doesn't mean that that always empirically has a positive outcome.
Right.
But
So this is a question of the right information, because information or knowledge is different from wisdom. So let me give you two examples.
Yeah.
Actually, you know, we know that in healthcare disparities, one of the biggest predictors is health literacy. And we know that minority populations do not have necessary health literacy to interact with the data that patients, providers may or may not give them.
Yeah.
And this potentially may actually exacerbate those disparities if the patient himself does not have that literacy.
Mm-hmm.
Second example, I'm an emergency medicine physician. You know, I have all these care plans for people who have various diseases where they have narcotic dependence. When I have this information on my hands, I can say, well, I'm not giving you this. Here's our care plan. This is what we decided as an institution. And obviously, we're restricting their access to narcotics. But if I did not have the information, or the patient was choosing what to tell me or not, I would be continuing to have the opioid issues that we have now, as the New York Times recently, right? So emergency medicine department prescriptions of opioids is linked to our narcotic dependence in our country. So I think that you have to actually prove that hypothesis and then decide what is that right calibration. And we shouldn't always think information is better, just like care. More care doesn't mean better outcomes.
I think it's a good point. I mean, I just think, you know, again, just kind of step back just for a second. I can see how the healthcare system over time could have evolved an attitude that says, you know what, we're going to protect you from yourself, right?
Yes.
And I think that may in certain cases have a reasonable justification. I think in a whole lot of other cases, it either had no justification or was in fact an excuse for a more nefarious motive, not impugning anyone's credibility, right? But so I think there's probably a balance to be struck, but it is not where we are today. It is absolutely not where we are today, right? We have to move much more strongly in the direction of patients getting their own information, and you know, we have to move down that path wisely and carefully. But there's no question it has to be different from today. Thank you for your comment.
Congratulations on the Blue Button Initiative as empowering patients. I was just curious, have you given consideration on giving visibility to patients on who's accessed their records?
That's interesting. So I haven't been involved in that myself.
We don't yet have from, I guess it's from the regulators yet. We're supposed to get an accounting of disclosures for the past 3 years from EHRs upon request, but the rules aren't out yet. I don't know where they are. Maybe Claudia knows.
But
Yeah.
the level of commitment, thoughts on your level of commitment to such an initiative, is that something that you'd support? Is that something that goes along the lines of empowering patients?
Yeah, of course.
Great.
Yeah, no, that's really yeah.
Great.
He's on
Thank
our
you.
side. Yeah.
Hi, I wrote a story about open notes for Health Leaders Magazine.
Oh, cool. You probably know more about it than me.
well, maybe, but one of the things that came up was this notion of tethering, and I know it's not a new notion, but it's a notion if people have a PHR, that the physician retains some ability to kind of have some control over, even after you've given the record to the patient. I'm wondering, does Blue Button do away with tethering? Is tethering a thing of the past?
It's a thing of the past. Basically, you just get your Blue Button file, and you can do whatever you want with it. You can take it wherever you want to go.
So they can't leave any hooks or any code in there that...
To call it back? No.
Yeah, all right.
No.
Thank you.
No. One more question? Yes, ma'am.
Last question.
I know there's a hospital situation where a patient found a mistake in their record, it was inadvertent, and they were told it couldn't be changed, but that they could do an addendum. So I was wondering if you had developed mechanisms or way to support patients to get changes made in the record if there's a mistake, because they have difficulty doing it.
We haven't, but we've heard that now that Blue Button is out there, we've heard that more and more times, and that's a spectacularly good idea.
Well, there's as many of you know, there's a process where we're supposed to be able to include an amendment, but nothing can be deleted for medical legal reasons, and we're supposed to have a process for that. Claudia might know more about it. No. Anyway, that's in the law. You're supposed to be able to amend.
But, I mean, the whole idea of actually making it easy for patients to spot errors and then be able to through amendments,
to send them back,
post corrections, and make that easy to do. I think that could just be one of the biggest sources of benefit to patients and providers, actually, of Blue Button. So all for it.
Thank you so much. Can I ask you one question before you leave? Okay. So since patients need to be able to make corrections, will we get a pilot where patients will be able to connect directly through secure email with their physicians, and that would be a mechanism to send an amendment?
I think we should try that.
A pilot, a patient-controlled data exchange pilot?
I think we should try that.
Thank you.
Absolutely. We'll work on it.
Thank
With
you.
your help.
Okay.
Thank you so much. Great to see you all.
Thank you, baby. Thank you.
Great.